Hello, and thank you everybody for tuning in today to our event on the challenges and promises of telehealth. Now, the whole COVID-19 pandemic has given everybody a chance to reassess a lot of things, whether they wanted to or not. And this is definitely true in the healthcare industry, as it is in every other sector of the economy. Now, healthcare is obviously traditionally a very high touch, personal service oriented sector. But what we've noticed is that as primary care providers have been forced to shut down over recent years, this is really over recent months with the pandemic. This has basically forced them to move to telehealth in a way that they never have before. Telehealth has been a discussion that people have been having for at least a decade, probably more. And people are now trying to figure out how it is to go from ideas and concepts that people have sort of advocated for many years, the idea of more convenience, the idea of more of medical visits fit around people's schedules, to an environment where telehealth potentially displaces in-person care, makes healthcare easier to access, and becomes a long-term way of delivering care to people rather than just a stopgap where people are trying to social distance. Now we've got some challenges though in the way of this move to telehealth. Big one is really the reimbursement challenge. It's one thing to say that people are allowed, the doctors, the nurse practitioners are allowed to deliver care by telehealth, but at the end of the day, if they're not getting paid for it, that's not going to happen. Now, temporarily, CMS has waived a lot of the restrictions around telehealth. Private insurers have done this as well. But in the long term, if telehealth is really going to make it to the big time, there has got to be some structural change in terms of the reimbursement opportunities and rules, especially in the Medicare program. And there are a whole host of associated regulations associated with that. Changing regulation obviously is a political decision that needs to be made, and that gets pretty complicated at some times. There are winners and losers from any kinds of change. There are a lot of complicated calculations that get made by political actors, by business, by government, by people in Congress. And our guests today are really going to try and filter through that. Firstly, what is the promise of telehealth? Secondarily, how far are we getting down this down this route to transforming potentially our delivery system? And then thirdly, how do we think about the political challenges and getting past them? So today I'm delighted to invite three guests. Firstly, Latif Malhotra from Harvard Medical School, who's here to really give us a sense of the research background on telehealth, what telehealth is doing currently, where it might go, what its potential impacts on costs and access to care might be. So Dr. Malhotra is a professor of healthcare policy and medicine at Harvard Medical School and a hospitalist at Beth Israel Deaconess Medical Center. His research focuses on delivery system innovations with attention to the quality of care, and has been really a pioneer thinking about telehealth and investigating really what the evidence says here in terms of how it might transform the delivery system in terms of quality and cost, and what the opportunities and realities are going forward. I also like to welcome Peter Antol, who's the Chief Medical Officer at American Well. Peter Antol has experience as a physician, a healthcare entrepreneur, and a physician manager. American Well is one of the nation, if not the nation's leading telehealth provider and platform. Dr. Antol is also president and medical director of the online care group, primary care group that really partners or works through the American Well telehealth platform, and so he can give us a real sense of like really what the challenges are from a business point of view, but then also from a clinical point of view, like from the docs that are participating in this and how it feels really from the provider side. And then thirdly, I'd like to welcome Robert Horn to really give a sense of the policy aspect of this. Robert is president of Forest Hill Consulting in Washington, D.C., an organization that advises institutional clients on how to navigate the healthcare landscape on Capitol Hill, and then also in the regulatory agencies, CMS and FDA. Robert has extensive experience in health policy FDA issues, payment policy issues. He was one of the leading forces behind the macro healthcare policy reform that went through Congress a few years ago, and then also the 21st Century Cures Act, which was a big priority of the Manhattan Institute with Peter Huber, really trying to speed the innovation on the pharmaceutical and device sides, which is obviously of huge relevance right now with the COVID pandemic. Robert spent over a decade on Capitol Hill, firstly with Congressman Gingrey, and then with the Energy and Commerce Committee, where he dealt extensively with Medicare payment policy issues and FDA reform. So I'd like to invite our guests. Thanks for joining us, and also thank you to anyone who's listening for joining us. I want to remind everybody that they can submit questions for our guests. There will be a Q&A session, and people can submit questions through the on-screen prompt. So I think we'll start with just really sort of getting, this is obviously a big issue area that people that our guests have thought deeply about, and I'd like to introduce them, and having introduced them, I'd like to give them a chance to offer their thoughts. So Atif, would you like to lead off?
Yeah, no, thanks for having us, and look forward to the input from those listening on the phone online here and their input. So we thought it might be useful to just take a couple of minutes just to lay the foundation on how the pandemic has impacted how Americans get care, and specifically related to telemedicine. And so I'll just go through a couple of data points that I hope will be helpful to the conversation. What I'm showing you here on this graph is really what happened on the visit side in the United States. So what you're seeing is each of the weeks on the x-axis starting prior to the pandemic, and then that baseline week is orange, is when things really went south in terms of both the virus spreading as well as the impact on how patients got care. And through the course of just 3 weeks, we saw a dramatic decline in the number of visits we were seeing to practices of all type across the country. Something I have never seen in my clinical career, where there was almost a 60% decline in just 4 weeks from the baseline. And then subsequent to that, as the pandemic has progressed, we have seen a rebound that has now, we're roughly, as the last time we checked, the week of June 14th, we're now roughly 11% down from our baseline in terms of the number of visits we're seeing per week to doctors in the United States. It's highlighted is a cumulative visit deficit, because I'll get back to it. It's a big concern is that our patients' healthcare needs not being met. Now, the conversation today is focused on telehealth, so I wanted to turn to that. What I'm showing you here is the same time horizon, but on the y-axis, I'm now showing you that of all baseline, the number of visits we might see prior to the pandemic, how many are provided by telehealth in that given week. So prior to the pandemic, people were using telehealth, but it was a very niche part of the healthcare landscape. Relatively few patients had experienced a telehealth visit, and most doctors were not using telemedicine. And at the same time, we saw the dramatic decline in total visits. We saw this dramatic rise in the number of telemedicine visits or telehealth visits. So to the point of by mid-April, we were seeing about 14% of all visits in the all visits that we would see at baseline provided via telemedicine. These are huge numbers. I should just give you a sense of that, which is that there are roughly 1 billion doctor visits in the United States per year. So if that 14% had continued throughout a whole year, that's roughly 140 million telemedicine visits. Changes that people have been talking about for decades, were expected to take years, all of a sudden happened within the course of just several weeks. Then it's interesting, since that peak in April, as economies have opened up, communities have opened up, we're interestingly seeing a decline in the number of telehealth visits in a given week. And I think one of the things that we'll come back to in our conversation today is why and how is policy playing a role with that. I just wanted to add two last data points. The first is that while telehealth has helped, it hasn't affected that overall decline. So I wanted just to explain that to make sure we're clear. What I'm showing you in the turquoise line here is what I showed you previously, that big decline up to almost 60%. In terms of in-person visits, it was down even further. So that gap between those two lines is provided by telehealth. So it has played a critical role in the healthcare landscape, but I want to make sure I emphasize that there still overall was a huge decline. The last data point I wanted to add was that it depends greatly on the type of care being provided. And that's illustrated a bit here by the specialties and their percentage decline. If you look at our psychiatrists, our psychologists, our social workers, they've really embraced telemedicine to a much greater degree and subsequently have not had as much of a decline as some of our surgical colleagues, where telemedicine is a lot harder to use. So when we think about the impact of both the pandemic on how patients are getting care, as well as which type of care they're getting, I think it's really important to emphasize. And I'll just end by just highlighting why this is so critical. As we think about the impact of COVID on the health of the nation, we're obviously focused on those that are infected. But I also want to emphasize that this spillover or secondary aspect is critical. Patients were scared, very scared, to go and get care. And we are seeing the health consequences of that. For example, we have seen a dramatic drop in heart attacks and strokes that are coming into the hospital. And as one of the doctors in this article highlighted, its patients are saying, I'd rather die at home than going into the hospital. And other patients, in particular those that have chronic illnesses or immunosuppressed, are very scared to even get some blood work done. And I think that's important to emphasize why telemedicine has played such a critical role. It hasn't been a panacea, but it certainly has been, again, the lifeline for these kinds of patients to at least get some care and potentially address their healthcare needs. So I'll stop there. Look forward to the conversation.
Thanks, Latif. That was very helpful. Peter, it'd be great to hear your thoughts from like the on-the-ground perspective.
Sure, great, thank you. And maybe I'll say a couple words, and then I'm also gonna go into a couple slides and bring in some data from our experience in the private side. So first of all, it has been quite a year. I'm sure you've all seen it, particularly COVID. But not only do we have COVID, but we have the economy and we have the social unrest and everything else that's going on. And I would say, in the world of telehealth, it's been an incredible year. It's been one of those inflection points that's totally changed the industry. My name is Peter Antol. I'm the Chief Medical Officer at Amwell. I'm also the president of Amwell's affiliated but separate medical group called the Amwell Medical Group. I'm a pediatrician originally and based in Southern California. I've been around this industry since 2008, back when it was only very expensive fixed endpoints, and we're in a whole different world now in which care can happen right on a smartphone or really consumer grade device that people carry around all day long. So we were excited that we could play a meaningful role here during COVID. If you remember back to early March, our healthcare system really was on the ropes. Things got bad really quickly, especially beginning in Washington State, up in Northern California, and then progressing across the country. And we quickly realized that we could play a meaningful role in that. Robust care could be delivered by us or by other known providers to patients through telehealth, but the virus can't travel back through the internet. So that notion of social distancing really made a difference. And particularly, as Atif has mentioned, as ambulatory care somewhat broke down or significantly broke down, patients needed other options. They didn't want to be in the emergency department. They couldn't see their PCP in many cases, especially for ill visits. They needed other venues and other ways to receive care for COVID-related illnesses, but also normal care for their diabetes and their hypertension and whatever else is going on. If we transition over to some slides, this was the view back in 2017. Eric Topol and Ray Dorsey were really talking about, and this was really considered very aggressive and very forward-thinking, that crossover point at which more visits in the future would be delivered electronically than in person. And I think I was on another panel recently with someone from CMS, and they said, what COVID did is accelerate the timetable like this by at least 5 years. This was, if we can see this next slide, this was our view. These little blips, 2015, 2016, 2017, look really modest. But when viewed on a smaller time scale, these were sort of hockey stick shaped. So each year, and these peaks are always during the winter. When we're talking about Amwell as a care delivery engine, not just a technology company, a lot of our care delivery is acute urgent care and things like this that tend to be seasonal. So each of these blips represents a flu season, and each year we were jumping up 2x or so, sometimes 3x in volume. But you can see what happened this year. I mean, in 3 weeks, we went to 9 times or 900% increases in volume. And not just in urgent care, of course. And that's just our clinical group. And I want to pause and say, keep in mind that you all may know us as an organization that delivers care directly with clinicians, but we see ourselves more so as a technology company. We provide software and hardware that allows providers to see their own patients electronically. And really, that's our long-term vision. As we've alluded to, there are barriers along the way that have inhibited engagement of the providers on the ground and caused them to be a little resistant to change. And we're going to talk some more about those in a moment. So, if we look at adoption over the last 5 years, back in 2015, about 5% of providers in our surveys disclosed that they had used video visits before. By 2019, that had jumped to 22%. And finally, as we got to this year, we've got that quantum leap. We got up to 80% or so in this survey that now claim they have used video visits. I mean, there are a variety of obvious reasons for that. Offices being closed down, patients needing care, waiver of enforcement of HIPAA played a role, allowed providers to just jump on and see patients using FaceTime and other non-HIPAA compliant vehicles. But what a change. And now we have all of these providers experiencing telehealth, engaging in telehealth, and understanding how it happens, how it's done, and what it might mean for their future practice, which we think is exciting. On our health system platform, so again, keep in mind, when we provide software technology, we provide a white labeled enterprise. I'm not here to sell anybody, but just trying to explain our business to various entities. Those might be health plans, those might be health systems, they may even be employers or other technology companies. The purple line here represents our increase in visits, basically from weeks 9 through 14, 15 of this year. Our visits within a 3-week period went up 3 times in urgent care. So we tripled our volume in 3 weeks and had to adjust accordingly. Our visits on Amwell platforms by other provider groups, by Cleveland Clinic, by Intermountain, by UPMC, they went up 22 times or 220%. Sorry, 22,000%, I think, if I'm saying that correctly. But 22x increase. So it was shocking growth. So much so that we were scrambling and on the phone with CEOs of technology companies trying to get emergency servers to beef up our technology capability to host such an increase. No, you can prepare for doubling, tripling, maybe 4x, but nobody's prepared for 22 times the hosting capacity of video hosting in 3-week period. To Atif's earlier point, so overall, what did that mean amongst our providers, amongst external providers that we're supporting? 7x increase in urgent care across all those platforms, but then we went as high as 50x increase in scheduled visits. And what scheduled visits basically means is these were not one-off visits with an unknown provider. These were visits with known providers and with their own patient panel. Those might be primary care, those might be specialty, those might be proceduralists. And again, that 50x, while that looks funny on this screen in terms of the magnitude, what that really represents, if you look back to baseline, there weren't a lot of those happening prior to week 10. And week 10 really represents that shift from ambulatory providers embracing telehealth and seeing their own patients. Now, and again, to Atif's points, those are coming back down. Primary care and ambulatory care is back open and for business. So we are seeing some of this go back and reverting back to normal state. But we're still at, I believe, I don't have that number on here, but I believe we're still at about 20x above baseline prior to COVID. So we're still seeing a dramatic increase, and a lot of providers still using telehealth as a normal part of their service. I'll go very quickly here. Pre-COVID, average hospital system had 2 or 3 use cases. Now average 6 to 7. Average hospital system had about 30 providers using their version of our platform, now up to average of 230. We've had some organizations that have enrolled their entire ambulatory enterprise onto telehealth as well. I want to just highlight consumers as well. Consumers have already enjoyed telehealth when they've had the occasion to try it. What we see now is we've seen a shift from 55% of our visits occurring with a first-time patient, now up to 75% with the new onslaught of all of these new patients trying out telehealth during COVID for the first time. Just to understand our case mix, we've seen anywhere from, in the last 3 months, from 8 to 12% of our urgent care visits are suspected COVID or CLI. Of those, 92% were patients that we were able to manage successfully in the home, what we call COVID-like illness stable, and 8% were COVID-like illness unstable, patients who needed immediate care, usually due to significant breathing difficulty. And the states that have been hit the hardest with those unstable, serious cases so far in our experience have been Florida, New Jersey, and New York. And then last slide, I just wanted to highlight, don't forget behavioral health. We also are a behavioral health company, both in terms of providers that we support as well as our own clinical operations. And in combination of those two, we're seeing 44 times the volume for talk therapy and 27 times the volume for psychiatry. I mean, these are explosive numbers. We can't recruit behavioral health providers quick enough. As soon as we recruit them, they end up with a full panel within days. So not only do we have a COVID pandemic in this country right now, we have a behavioral health pandemic, in my opinion. So I will stop there. Let me just say it's an exciting time to see telehealth being engaged. There is still a lot of work to do, especially on the regulatory and reimbursement front. So look forward to discussing that more.
Thank you, Peter. That was great, very illuminating. Robert, from a policy point of view, how does all this look? Obviously, people have been working on telehealth for many years. What's changed this year, and where might we be going or not going?
Well, Chris, thank you. And honestly, it's the last 2 speakers have been very informative and really helped set up this part of the conversation. I think from a way forward standpoint, it's a mixture of good news and bad news. I think the bad news is that reform, legislative reform, is still needed to realize the full vision of telehealth. The good news is that we really have advanced a lot in our mission to achieve that goal over the last couple of years. And in a couple of areas I might highlight real quick. First, Congress has promoted and passed a number of expansions for the use of telehealth over the last couple of years. Unfortunately, they've been largely focused in certain areas of medicine, home health, and some others, but certainly representative of Congress's support. And, I'm here to tell you, Congress's support is ongoing. Number 2, the administration has been given recent flexibilities by Congress to really expand the use of telehealth during COVID. And I think to the last speaker's points, COVID has created almost a national demonstration opportunity for us. We are realizing a place in which access isn't normal, access to care, that is, isn't normal anymore. And to the previous speaker's points, we've got patients with illnesses and conditions and situations in which normal access is not appropriate. All of that has led to both a greater embrace of telehealth, as the previous speaker spoke about, but it also, in conversations that I've and others have had, really, I think the feeling from both Congress and the administration is we want this to continue. We don't want to take a step back. We don't want to release some of what we're doing or stop some of what we're doing in telehealth today. We'd actually like to find ways to do more of it. So that's all good news. The rest of my presentation, I'm going to focus on maybe how we can do that. So in our time, I'll try to be as specific as possible, understanding that there's some details that we just don't have time for. But in thinking about really the argument for telehealth and then the way forward. It really, this argument of it increases care access and use and makes individual cases for care access and use easier on individual patients. That is an argument that policymakers understand. I think, the recent advances in digital technology have also, I think, helped telehealth as well, because people are starting to realize the efficiencies that can come with a digitally supported medical access and care model. And so, from the vision of the future standpoint, though, the good news is the one area I didn't mention in my support is the market. The market's already starting to move into a future of pandemic preparedness and ensuring that there are access avenues in place for patients no matter what happens. And a good example of this really is something that I'm starting to hear of, is a virtual hospital, where really, if you could think about it, it's a whole suite of services supported by face-to-face interactions, digital interactions, all molded together with a payment system that really does present new opportunities for patients and for payers and providers to really facilitate care, both in normal times, but also emergencies. Largely, the issue continues to be this. In areas where telehealth policy needs a change, and that change is legislative, how the Congressional Budget Office views the spending and use of any new law weighs heavily on the minds of politicians. And just to cut right to the chase, what CBO is really going to be looking at is, how does your policy impact spending? Does it go up? Does it go down? And how does your policy impact the quality of care available to patients? And so as you think about ways forward, there are really 5 buckets that I'd like to focus on, and then talk about a couple of thoughts to address those. The first bucket and the first 2 buckets are probably the most important. The first bucket is payment. And as Chris and others hit on, the payment mechanism that you use to fund telehealth will be of import to CBO. And it will, in part, it has in the past presented an obstacle to care. And what do I mean by that? Specifically, if you think about telehealth and attaching it to the current system as it exists right now, this is a fee for service. This is every time you use a service, you pay for it. CBO has tended to look at those a little bit negatively. Now, Congress has found a way through that. And as I mentioned earlier, Congress has been successful in some very targeted legislative packages. And that's almost their way of dealing with some of these cost implications. The neat thing about the market, though, is, and I think in saying this, there doesn't need to be a departure from fee for service per se. But really, you can think about taking fee for service philosophies and applying them to new payment models like global payments and other types of arrangements like that frankly better support the benefits of telehealth, easier use and potentially lower costs. The issue isn't to suggest that telehealth should save money. In fact, what's been going on right now, there may be some appetite in Congress to spend money on telehealth expansions, but it's just important to note that that's where CBO comes from. The second main bucket is something that it's multidimensional. I don't have a lot of time to get into it today, but that's really around functionality. And, from a policy standpoint, policymakers want to know, what are you using the technology for? What is it compared against in terms of a clinical model? And then what are the benefits or negatives, let's say, for the patient with that new technology in lieu of what happens today? And so as you think about functionality, and the reason that functionality is important is twofold. One, Congress is very worried about privacy issues. And so, how does the technology facilitate care, and how does the technology address any privacy concerns that come up? That's a policymaker consideration. The second side of functionality is really one of the medical service itself. Is it being generated from a living person, or is it being generated from a technology platform? In areas of behavioral health, as one example, we're already seeing where both are available. And so from a policymaker standpoint, it's not only just the mechanism to share care or to access care, i.e. telehealth, but really policymakers are starting to get into the functional aspects of digital health and how to incorporate those into new models of the future as well. Last couple of issues, and then I'll get into a couple of next steps and suggestions. But number one is really fraud protections, as we hit on earlier. Do these policies make it easier or harder for people to defraud the government? Unfortunately, CBO's view of CMS is that it's not excellent at protecting against fraud. And so while the technologies and all of the operations that are happening in the market are above board, CBO may have a negative view of CMS that way. That's all pretty wonky background. And so what I'm going to do now is just wrap up in a couple of next steps. Number one is treat what's going on right now as a national demo. Gather data and use and really think about that data as helping to inform policymakers of where problems don't exist or are already being addressed. Number two is create legislative strategies that help policymakers address the buckets that I just covered. And then number three, don't be afraid to embrace new policy ideas. The good news is policymakers want to solve this. They have some material problems, but innovative policy can really advance telehealth without sacrificing anything and do it in ways that make it easier for Congress to pass it. I'll stop there, but thank you very much.
Well, that was very helpful, Robert. Thank you. And you certainly raised a bunch of issues that we'll circle back on in a few minutes. I think what we've seen with a lot of the changes that have happened with the pandemic, especially, for example, telework, is we've seen an immediate shock, and we've sort of wondered, is there an enduring change in norms? Will there be, say, for instance, millions more teleworkers than there have been in the past? And it's a similar sort of question with telehealth as well. Peter, I'd just be interested to sort of have you flesh out, what is the best case scenario that we can hope for in telehealth? Like, what is it that people in the industry are excited about? What is it the patients to be excited about? What are people really working towards and hoping will happen in the long run, or even the medium term?
Yeah. Thank you. Great question. I'm sorry, I just jotting some notes there. So, listen, I want to clarify. I think there are misconceptions sometimes that telehealth is a distinct specialty, or that it requires some level of a special training. Our view is that telehealth is another venue for care. Simple. Stop right there. Providers provide care in a number of settings. When I was in practice, I saw patients in my ambulatory setting. I saw patients in the ER. I saw patients on the inpatient side, and I did telephone calls. I adjusted my care based on what the needs were in each of those settings. So patients have a variety of needs, and I think what telehealth does is it allows us to think differently about how we project the abilities of providers in new and more efficient ways. Number one, how we build new models of care, team-based care, collaborative care. Number two, how we improve access by doing things like solving for geographic disparities, specialists to rural areas, all of those things. And also at the same time, what we're able to do is make care really patient-centric. We talk a lot in hospital settings about patient-centric care. It's been a big buzzword for a decade or more. What's more patient-centric than a patient who has a minor need for a known condition, connecting by video with their primary care provider, who has a chart in front of them, knows the patient, has all their information, is able to adjust a medication or go over a lab test. Patient never has to leave the house, never has to go to a waiting room. We can improve compliance potentially. There's potential to improve compliance. Research by people like Atif need to be done to demonstrate that. There's certainly some emerging evidence that we can decrease no-show rates in certain areas like psychiatry where they're very high. And so I think we're very excited about that, about more efficient utilization of our provider supply. So that's one thing. I would add just two other things. One is that new models of care are being built today. I would highlight Joslin Diabetes Center has demonstrated, even amongst their own patients, A1Cs are still climbing. And amongst our country, our standard of care, the wonderful brick and mortar standard of care that we have, is still experiencing increasing population A1C levels. So we need to do better. We need to build models. And telehealth affords us, it's one tool in our toolbox. And Joslin used it to do more frequent touch points with patients. They didn't say, come back and see me in 6 months to find that the A1C hasn't budged. they said, let's check in every 2 weeks. Sometimes you'll check in with me. Sometimes you'll check in with my diabetes educator. Sometimes you'll check in with my dietitian. And let's keep on you. Let's keep nudging you along so that we make real progress. So I think that's exciting. And then the last thing I would say is there is a lot of disintermediation, a lot of noise, a lot of interoperability challenges that are inherent in our healthcare system. And there are opportunities. We're not going to solve all those problems, but there are opportunities to bring patient-specific data into encounters, to analyze that data a la remote patient monitoring through algorithms, to have an escalation to a live visit right where the patient is, and to continue to nudge that patient through text or other mechanisms on an ongoing basis. So bringing in data, analyzing that data, using AI, using chatbots, and having ongoing nudges and touch points with the patient. So we're excited about the future. We think there's so many ways this tool can be integrated. It's not going to replace in-person care, but it will replace some of in-person care, and we think we can do a lot of exciting things.
That's very intriguing. I think, well, firstly, I'd like to remind everyone that that they can submit questions online. If you have a question for either of our guests, please send that in. But one question that we've received, and it really brings up the issue that I think is an issue with a lot of these remote work arrangements. Like we've noticed that teleschooling has been a bit of a disaster. Like people really don't like having kids at home and trying to do K through 12 education. Is there with telehealth, it seems like something you might want to do anyway. There are some quality advantages potentially, especially like on chronic disease monitoring. It allows a quality of care that we haven't had so far. But then Atif, you in your presentation showed that as people were able to go back to the in-person consultation, that telehealth utilization has sort of fallen off a bit. Are we seeing that telehealth is an inferior good, or is there a quality drop-off? Is this inevitable? Is this likely to go away, or does it really depend what we're talking about? How does the quality aspect of this look?
Yeah, so I think that there is a premise, and sometimes you'll hear this idea that, oh, because telemedicine has all these positives, it can be used. And there are a lot of applications where telemedicine is a high quality option that can provide care. But I worry that some folks, maybe some telemedicine advocates, are saying it can be used for everything. And I think it's very clear to me as a clinician, I think almost anybody else, there's a lot of applications where telemedicine just doesn't work. For example, one of the writers wrote about listeners said something about a cardiology visit. And I think that's another example of where it doesn't play a role. And so we are still trying to figure out when it can be used effectively and when it cannot be used effectively. And we're going to try to figure that out, just as we're going to think about with teleschool, when can that option actually add value or not. And I do think it's important to emphasize this is not a binary, we do telehealth or we don't do telehealth. To maybe echo what Peter said, it's going to be part of the larger ecosystem that we provide. The other point that I think is really important, and that one thing I do get worried about right now when we have this conversation about telehealth, the conversation is about video visits. And video visits are a small part of a larger idea of what telehealth can be. And there are a lot of really innovative models out there that go way beyond a video visit. And the example that was just provided about diabetes care. So, we have some new teleendocrinology providers who are coming in, and they're doing some really innovative models. They're giving diabetic patients monitors that they can do 24 hours a day, continuous glucose monitoring. They're giving them apps so that they can track their glucoses. Those apps can give them feedback every day, every couple of hours about what they should be doing. They add that with text messages, phone calls, video visits, and they add a full package of where they are using technology to improve the care that patients receive. I bring that up in this context to make sure that we don't lose sight of that innovation, those really interesting models, but to also explain why it's so complicated as we think about the payment rates for these kinds of telemedicine. Because you can kind of see how you could pay for a video visit, and we are paying for video visits, but there's no way that we could pay for every text message and every phone call and every video visit and every hour we monitor someone. And that's when we have to think really outside the box and think about, okay, if we want to encourage that kind of innovation and those really interesting new models, how do we pay for them in a way that goes outside paying for a video visit?
Thank you. I think that's a really key question that I think we'll probably circle back on in a little while, because I think the key theme here is really the payment is going to really, you get what you pay for in healthcare, and this is going to be true in telehealth as for anything else. But I think another thing that I certainly notice in healthcare policy, I think everyone who works in the area notices, is that we have the same debates over and over again. And if you pick a book off the shelf that's 20 years old about a policy debate, pretty much the arguments are the same, and the challenges are the same. And yet we saw this radical sort of hockey stick graph that Peter showed us of sort of interest in telehealth. Robert, is the politics different this time? Or is there a sense in which we can kind of move beyond what you were saying as a CBO constraint or regulatory constraints? Has anything really changed, or are we going to look back at this in 2 years' time and say, oh yeah, we had these fun discussions where we thought telehealth was going to take off and nothing actually happened?
Yeah, Chris, it's a great answer. I'll give it in 3 parts, and I'll try to be concise here. Number one is, I don't think we're going back. I think the question is, how far forward do we go? As long as preparedness for future national health emergencies is a political priority, telehealth is just really it's such a solution that it'd be hard to walk away from it. So again, I think the question is, how do we go forward, and how much forward can we go? Number two, I just want to touch on the last point really quickly, and then I want to get into kind of just your question. But Chris, on telehealth too, as you think about a way forward, and just to go back to Ativ's point, the telehealth story you tell is really key to success here. It's not a cure-all. It's not. At least it's not today. But as you think about it, on the positive sides, there are some areas of telehealth that are showing improvements over standard of care. Behavioral health is one of those examples. And again, I've heard this from a couple of clinicians, but just the ability over Zoom to look into a patient's surroundings, how they live, is really helpful in the care that they provide. So, again, as people engage Congress, find those areas that are really conducive, I think, to improvements in care. And then, lastly, let's just anticipate that technology will continue to evolve and get better. And so from a policy standpoint, yes, it is true that there are things that telehealth can't do today, but my expectation is in 10 years, I think we're going to think about telehealth differently than we have today. And just like we did 10 years earlier. Chris, I think the way forward in Congress right now is, I think if there are opportunities for different communities to work together, I think that's going to be key. And the second thing is, I think the market's doing a lot of neat things around payment and other types of governance issues that really address some of Congress's concerns around privacy and things like that. And so, really, I feel like the opportunity is ripe. And I feel like if there's the right policy in front of Congress, you're going to get Congress excited. You're going to get the administration supportive. And it could be one of those quick acting legislative vehicles.
Thanks, Robert. Sorry, did anyone have any sort of further thoughts on that? Or I actually sort of have to turn to the questions that people have been submitting online. We have a question from Jeff Flyer, who's asking which institutional actors will resist increased telehealth, and why might they be doing so? Is there a way to sort of avoid that, to resist that, to get around that? Robert, I guess this is a political question again.
So short answer is yes. I think there's some real pitfalls. I know folks have talked about HIPAA before, but really it's the way to think about privacy policy. It's very, very important, obviously, to protect the privacy of patients. Anytime you take individuals and you put something in between them, like technology, there's the chance that privacy and safety of data could go down. And so as you think about the actors of the institutions, you can really think about some of those policy inflection points that may help identify them. Consumer groups obviously are very concerned about digital use, and they're trying to apply, I think, some HIPAA protections there. I think largely CMS had been a little bit hesitant. That seems to have been eroded. And, arguably, I think the last thing is some of this disruption has the potential to change the provider model of care. And I think you're going to see not the entire industry, but within subsets, you're going to see this tension between no, we want to keep the system we have versus no, we want to do this. And I just think back to Ativ's point, the way forward really may be one in which it's a flexible system that allows for people that want to use it in ways that are allowed for, and that those that do not, let's say, cannot. But so I guess maybe the point is this doesn't have to be a zero-sum conversation, and it has been in the past.
Yeah, and I would just add in the industry side, I think we see, we work with lots of hospital systems and health plans and employers, and those that are embracing outcomes, those that are embracing risk, those that are most interested in consumer experience, are the ones that the organizations that tend to engage, whether that's a health system, whether that's an employer or health plan. The lack of alignment is still a challenge. You have a health plan who is paying the bills, or an employer, they see those ER claims for unnecessary ER visits, for example, in the urgent care space, and they see utilization of out-of-network specialists and all the other things that happen. They're really motivated, but then you have to get the health systems aligned with that. And the best way to do that is alignment on value-based care. And when we see those organizations that are thinking in that way, or that are integrated and have their own health plans, are taking on risk-based contracts, those are the ones that we see engaging vigorously these days.
I might make 2 quick points to add on that. So the first thing going back to Jeff's question, which is about who are the people who are going to resist this. And I think a lot about the large existing in-person providers, your big health systems, as well as your practices. And I think there's a lot of hesitation there. Certainly within the context of the pandemic, they're using telemedicine, but I think there's some concerns about how this will play out. And there's 2 pieces of regulation that really I think about. The first one is a requirement that many payers have introduced, which is before you can provide a telemedicine visit, you got to have an in-person visit. Right. And also licensure laws, which require the physician to be licensed in the state that the patient is located. Both of those are very problematic from an innovation perspective, because they limit companies that are introducing new clinical models that are trying to provide national care. So, and I'll just give one example of that. We were working with a number of opioid use providers. We have an epidemic right now. They're introducing these really interesting models, but it's very, very difficult to set up a model where you need to have an in-person visit, as well as then getting each of your providers licensed in 50 states. So I'm particularly enthusiastic about as we move forward, first to remove that clause about having to require an in-person visit, as well as there has been some calls, and this might be too far, and Robert can mention this, but to think about interstate commerce and really whether we need to move to a new framework of not having a single licensure in each individual state, but moving to a larger national framework. That's a big call, but I think we're at that point where we have to recognize that's a major issue.
Yeah.
If I can just add to that, I guess Atif completely agree. The ideal way forward would be start with a white piece of paper, so we don't have to deal with all of these restrictions and weird things that have been layered on telehealth, because that's the issue. Innovation hasn't waited for CMS policy to change. The market hasn't waited, but this certainly is a huge inflection point that it has to be addressed for the vision to be realized.
And I would just add, we're a member of the Alliance for Connected Care, lobbyist organization in Washington, and the stance we're taking these days on licensure. First of all, the license reciprocities that came up during COVID were incredibly valuable. We were able to project our entire network of thousands of providers all into New York, because New York gave license reciprocity during the period where they were in such trouble. It allowed us to really help them. But the Alliance is moving towards a stance in which we're going to be advocating, it looks like, for a federally sponsored licensure compact. The Federation of State Medical Boards existing compact is sort of halfway there, half pregnant. and not enough leverage. So we're really looking at some of the models in the past around adoption, around drinking age, and some of the other things in which the feds sort of pushed the states to come up with a unified position in order to gain federal dollars or things like that. So that's still a work in progress. We're still floating that out there as an idea, but it's only one solution. I mean, a federal license would be wonderful, but I think the belief is that might be a step too much or too far
Peter,
for Congress.
I'll tell you what, if I can just share a thought, maybe, if it's couched within the preparedness plans for a future pandemic or national emergency, you might have some area there. And I mean, again, this goes back to kind of pick the best environment to have the conversation and then see what you can get done. I think in behavioral health, and I think especially on pandemics, they don't have a solution. And so they might be more willing to support something like that in that case.
Makes sense.
So we have a question from Donna Rosado, which I think kind of gets to the crux of a lot of these questions. And that's, where the question suggesting that giving people access to telehealth that they didn't previously have, that's giving them more things, and that just going to bring more cost for consumers, but also potentially for taxpayers. Like, we have this concern with cost. Robert, you mentioned that CBO is very concerned with cost. If we're giving people more convenience, are they just going to go to the doctor for like more routine visits for things that are really not kind of borderline? It's not necessarily going to mean better outcomes. It's just going to inflate the expenses that are occurred. Atif, I'm curious to hear your thoughts on that.
Yeah, so I think it's a very significant concern. So when we think about the impact of telehealth, some people have advocated that these are going to be substituting for doctor's visits. But then the question that Donna's raising is, are the patients going to get more care? And so we published some research documenting that the vast majority of the telehealth visits that we were looking for in that particular clinical area were new visits, people getting care. About 90% of those were, and that increased healthcare spending. So, I told my, father about this amazing research that I was doing. And I said, Dad, when you make things more convenient, more people will use it. And, my dad, well, only as a dad can do, looked at me and said, ooh, fancy Harvard professor, proving the obvious. So, I mean, it makes sense that would actually play out. And so I think it is a very significant concern. And that's why I think we have to be extremely cautious about laws that are just going to open up this telemedicine to everybody across the country. And that's why I'm much more enthusiastic about smaller expansions of telehealth into certain clinical areas where there is substantial value. It's been already raised about behavioral health. I would bring opioid use disorder, maybe some chronic illnesses, but the idea that we can provide telemedicine and we as the taxpayer should pay for telemedicine of all types, I think I have a lot of concerns about that overutilization problem.
And I would just add that you have to look at each different use case differently. If you're talking about follow-up visits with a PCP, that there is a normal level of titration based on the availability of a primary care provider and the cadence in which they suggest follow-up visits. Also, Anthem, we work with Anthem. They published an article with HealthCore looking solely at a 3-year experience in urgent care alone. Telehealth by urgent care, they found a net savings of $140 for every visit that occurred. And the way the math worked was, yes, there was a slight bit of increased utilization. I think it was 5%, 4 or 5%. But these were lowest cost visits, lower than the cost of a visit in person in an ambulatory setting, much lower than an urgent care setting, and a heck of a lot lower than the cost of an ER visit. And they found that there was enough ER diversion for unnecessary ER care that there was a net savings at all times. So again, overutilization needs to be studied more. It needs to be understood. I understand all the points being made, but when we, keep in mind the telehealth, there are efficiencies, there are cost efficiencies, as well as other efficiencies, number one. And number two, our current healthcare system in which patients go to the emergency department for sore throats is there's a lot of waste. And Chris, so there are efficiencies to be gained as well.
And Chris, just a quick 15 seconds. I think it's, from a policy standpoint too, if you think about approaches that have been successful in the past, people have largely focused on populations or subpopulations for policy. And then they've also focused on sites of care. A third area that may prove of some benefit to policymakers or in certain areas might be to focus on functionality, where you're developing policy around a function of telehealth in ways that addresses some of the buckets that we identified earlier. And I say that because that's really how the FDA regulates products too. And so there's some harmonization opportunities between those two that may make sense.
And maybe one other point to make, just in the context, it's not quite about cost, but tangentially from the question, COVID was a unique situation, right? And March and April, we all remember our ambulatory systems were breaking down, our ERs were overwhelmed, our ICUs in many places were overburdened or over capacity. But telehealth played the use of telehealth by many different entities on many different platforms played a meaningful gatekeeping role during that time. So not only were we seeing patients who had other chronic diseases that needed care and couldn't get care, but we did a lot of work, and we coordinated in our organization with the CDC directly on policies to get people to the emergency department safely if they need that care, and to do a white glove transfer so that they don't infect the whole waiting room. But at the same time, as I showed in the slide earlier, to keep that 92% or so that might have COVID-like disease, but that can be, at least for now, safely treated in the home, to keep them in the home and keep them out of the emergency department. Our ER partners were asking us for help because they were overwhelmed. There were 4 and 5 and 6 hour waits to get, seen in the emergency department, even if you had something relatively severe. So I would just keep that in mind as well in the context of a pandemic there, and it's slightly separate from the cost question. There was an incredible value in using telehealth solely as a gatekeeper.
So we talked a lot about patient to provider telehealth, and obviously in the context of social distancing and the pandemic, this has been the big challenge that's sort of changed the game. But it seems like a big part of the telehealth opportunity is almost provider to provider. So a doctor working with a specialist, or a nurse practitioner working with a doctor at distance. And you don't necessarily have the same volume challenges or convenience concerns about utilization associated with that. Is there an opportunity almost under the hood there that's bigger, or is that overblown? What potentially is the opportunity out there on the sort of under the hood on the provider side?
I would. I'm sorry for jumping in, Chris, but there is a great opportunity for both on the outpatient side and the in the emergency department, and it's already happening. Let's be very clear about it. So in emergency departments across the nation, they often don't have the specialty care that they need, and so we see almost half of all emergency departments now are using telemedicine to get in a psychiatrist who they need, or a stroke expert who they need for treatment, and those are all happening, and they're paying for it out of their own pocket through the payments that they're receiving because they see the value. So I think there, in that particular context, it's already happening, and we should just keep on encouraging it. The one thing that is out there that is a little problematic is our smallest rural hospitals are least likely to use it because this is expensive. So that may need to be addressed from a policy perspective, but I just wanted to emphasize in many ways that model that you're just describing, Chris, is already happening.
Yeah, and if I can just put a plug in real quick, I think too, the broadband issues come up a couple of times on this call, hugely important. And I do think there's some areas on the Hill, Drew Ferguson is one that comes to mind, that very much sees the connection between broadband and telehealth. So just some very good opportunities to have a broad conversation on this. Very exciting times.
Yeah, a couple real quick points. One is I would highlight there are some organizations, Avera, for example, health system in South Dakota, that is doing an incredible job of projecting support to rural hospitals through telehealth for ER-based support, running codes and things like this, for geriatrics to SNFs and various other supports to critical access hospitals. So very successful work being done there, sort of a hub and spoke kind of model. I would highlight behavioral health and psychiatry. Such a shortage of psychiatry in ER settings and inpatient settings, and the ability to project them in electronically is happening. We purchased a company recently called Align Telepsychiatry that is in this business, the inpatient and ER psychiatry business, provider to provider. And I would just also highlight, this is there's an ability to extend a provider's career. If you have a neurologist or an orthopedist, especially we've seen orthopedists who are getting past the stage in which they can be in the OR anymore, but they can still do consults in the ER by telemedicine. it really is a unique opportunity to extend careers and get a little bit more specialty availability out there in the community.
And then, Chris, just one last thing. As you look into the future, the success of models in part is predicated on the ability of providers to accept and succeed in a risk environment. The ability of technology to allow a provider to work with other providers to better manage that risk could help models succeed today, but frankly, also could help establish new model opportunities in the future.
Any final thoughts from anybody to add on to that? Well, thank you everybody for joining us. We're finishing just in time. This has really given everyone, I think, what is a nice little sample of the debate. It's obviously a debate that has many aspects, and Congress will revisit it, the administration will revisit it, and the healthcare system will certainly be influenced by its changes over the years to come.